Good afternoon, everyone. Welcome to the EASL Studio, your weekly hepatology broadcast news. And in today's episode, we're going to be discussing, is there a role for measuring ammonia in patients with cirrhosis? And I'm absolutely delighted to be joined by a real expert panel. I've got Professor Sara Montagnese from the University of Padua in Italy and also the University of Surrey at Guildford. We're also joined by Professor Elliot Tapper, at University of Michigan in the USA, and lastly, Professor Rajiv Jalan from University College London. I don't think anyone really needs any introduction. And I'm also pleased to say that we're delivering this studio in collaboration with ISHEN, which is our International Society of Hepatic Encephalopathy as well, who are supporting the studio today. So maybe to begin with, Rajiv, could I ask you, for those watching the studio today who perhaps aren't so much experts in the field, why is ammonia so important, and why is it relevant when we're talking about encephalopathy, or perhaps also more widely in patients with cirrhosis?
So look, ammonia is produced in large quantities in the body, and it's sort of a byproduct of amino acid metabolism. We produce millimolar quantities of ammonia. And you know, the liver has evolved as the organ that has been designated to deal with this large amount of ammonia that we produce. And, you know, so we evolved through millions of years, this amazing urea cycle, which resides almost exclusively in the liver cells. It's a complex system, which is in the mitochondria and the cytosol. And whenever nature organizes itself to deal with something like this, it is to deal with a very strong toxin. And so therefore, ammonia is an extremely toxic molecule that can produce cellular dysfunction across the board. Neurons are very sensitive to ammonia. At 5 micromolar concentrations lead to almost death of ammonia because it cannot tolerate the toxic effects of ammonia. And Debbie, as you know, you showed that even 50 micromolar ammonia could produce serious neutrophil dysfunction. Dasarati has shown very strongly that ammonia leads to sarcopenia. And you know, so wherever you now choose to look, there's now associations with cancer. So therefore, ammonia, the liver is not working, ammonia levels will go up. It'll affect the brain quickly because the neurons are very, very susceptible to the effect of ammonia. And therefore, we have to try to keep its levels in check, not only to prevent brain dysfunction, but to keep the rest of the body healthy.
Thank you, Rajiv. And I mean, Sara, maybe I could ask you, how do we measure ammonia? Do we take a venous sample? Do we take an arterial sample? How do we go about doing that in sort of a clinical practice and in clinical settings?
Sure. We don't really need an arterial sample. There's dated but very convincing work from Professor Ferenc's group to show that venous ammonia is more than adequate. What is very important is that once the blood is taken, it is kept cool, and the measurement is actually performed within 90 to 120 minutes. This is because if the blood rests, and especially if it rests in non-cool enough conditions, ammonia can fatally increase. And this is something that will also be relevant probably to our subsequent discussion. So venous is enough. It has to be kept cool, measured fast. If anything happens, it will most likely be a false positive. So the problems with ammonia measurement, if any, and if not done properly, is hyperammonaemia, which is not true. So if you, in a sample, find the patient to be normoammonemic, this is unlikely to be a measurement issue. Still, protocol should be in place and the sample should be processed fast and kept cool.
Thank you, Sara. That's really helpful. So, Elliot, obviously Rajiv's told us a lot about why ammonia might be important, but there's also been a lot of debate over recent months to years about the relevance of measuring blood ammonia in clinical settings. And that's one of the reasons why we set up the studio today, and lots of controversy. So do you think you could sort of comment on why there's been controversy and why there's so much debate?
Yes, thanks for the question. Without a doubt, ammonia is a toxin, the toxin which is responsible for hepatic encephalopathy. But the challenges are really twofold in interpretation and contextualization of a given value for a patient, and in the finickiness of the test, as it's expressed in the duality of our professional lives as both clinicians and researchers. Whereas clinicians, we are faced with patients who come in with complex disorders, comorbid sepsis and alcohol. And when we see somebody with asterixis or coma, we are left to treat that person and use their outcomes as the ultimate arbiter of what the underlying cause of their presentation might be. And sometimes the ammonia levels are low or high. And as researchers, we've learned that it is very hard to measure this test perfectly. And this results in some challenges across centers where the interpretation of what a given level means for our patients will be difficult. As in one center, it could mean that it's high or low, or in the other, the exact opposite.
Okay, thank you very much. And actually, it's interesting because we've had this debate. We've asked our listeners and our viewers on X actually to do a poll, and many of you very kindly participated this week. And we actually asked the question: is there a role for measuring blood ammonia in cirrhosis? And 171 of you voted, and 28% said yes. 37% no, but actually there was a 35% that actually said it depends on the clinical scenario. So what I thought might be very useful now is if we actually think about some clinical scenarios and where there may be some utility to measuring ammonia and where there may not. And if let's take this scenario maybe to start with. So you've got a patient who has got known compensated chronic liver disease, and they're admitted to your intensive care unit in a coma. The CT scan of their brain doesn't really show anything very exciting to suggest a reason why they might be in a coma. And you're called to see the patient. Do you think measuring a blood ammonia level would be helpful here? Maybe I can go to Sara first. What's your thoughts?
Yeah, I would definitely measure ammonia here. This is a compensated patient with quite deep coma. And should I find a normal ammonia level, I would exclude the possibility that I can call this situation hepatic coma or hepatic encephalopathy. And therefore, I would worry very fast about excluding meningoencephalitis, status epilepticus, any other cause of delirium or coma. So for sure, I would measure ammonia in this situation.
So it's a yes from you. Maybe Rajiv, next, what would you do?
Yeah, so absolutely yes. I think there are two aspects to this. The first is really, I would want to express that ammonia not as a number, but as the upper limit of normal. And this comes to the point that Elliot was making earlier, that, so that ammonia is interpretable across the world, we have to move away from describing ammonia levels as a number, but as an upper limit of normal, very much like the INR, so that everybody understands what we're dealing with. This is now validated. It's been published by many groups. That upper limit of normal is probably the way to go rather than the number. The second, in addition to the diagnosis, I think what is absolutely crucial, I think, is that it gives you a number to aim to target. So let's say it is 3 times the upper limit of normal. And so you remeasure in 24 hours, 48 hours, 72 hours, because that change at that ammonia level is the key to that patient waking up. Because at 48 hours, if it doesn't change, you would want to resort to a CRRT or what have you. So it is not just a number, it's a number that you want to target for therapy.
Okay, so it's going to guide your therapy. And what about you, Elliot?
So what you've described is a patient with undifferentiated coma, and I completely sympathize with the perspective that ammonia could be useful, because we know, as Dr. Montagnese points out, that the negative predictive value of ammonia is very high, but even the data underlying that shows that it is not a perfect negative predictive value, because indeed a little bit of ammonia goes a long way in people who are also presenting with sepsis. So from the perspective of a clinician, and in the data that we have from groups like Hodge et al., we would know that somebody who has grade 4 HE could have a low ammonia if they're also suffering from sepsis. So what would I do? Would I hammer them with lactulose until the cows come home? No, but a time-limited trial of lactulose whilst I'm also managing their underlying sepsis is reasonable. And in that context, the ammonia might not be as clinically persuasive as many would hope.
That's a good point there. And actually, your opinions actually really represent the poll we had on Twitter this week as well, or X rather, in that actually we had exactly 50% saying yes and exactly 50% no. So I think people really appreciate that there's even nuances around that. So that's very interesting. So maybe I'll put another scenario to you now, slightly different one. So you've got a patient with known alcohol-related cirrhosis, and they present to the emergency room confused with a flapping tremor. And you're pretty convinced this patient's got overt hepatic encephalopathy. But should we measure ammonia in that sort of situation? Because some people do and some people don't. So I'll go with you straight away, Elliot. What would you do in that scenario?
Yeah, so this is a situation where the pre-test probability of overt encephalopathy is so high that no matter the result from that ammonia, you're not going to change your diagnosis. And we prospectively assessed the Bayesian characteristics of ammonia testing in the emergency department. And when somebody presupposes that the patient has HE, no matter the ammonia level, that's ultimately what they're diagnosed with and in fact managed with. But I'll put in a point for the other side, which is that the higher the ammonia, the sicker that patient is, adjusting for all else. So if you want prognostic information, it's there. But clinical information, I don't think there's any added value.
Thank you. And Rajiv, Elliot mentions prognostic value. How could this be valuable to prognosticate in this sort of patient?
No, thanks. I think you're completely right. I completely agree with Elliot. There are many papers now that suggest that if your ammonia remains elevated despite treatment at 70 or more micromoles per liter, the risk of death is very high. And so therefore, for me, this patient, I would do the measurement of ammonia and I would use it to guide, therapy and where the patient should be managed as we move forward. 3 days later, if the ammonia is still 70 or 80, the patient should receive CRRT to remove ammonia in this situation. So the cutoff values are about 2.5 times the upper limit of normal. It's an independent predictor of mortality in this patient population.
Okay, and Sara, what are your thoughts? What would you do?
Well, I would definitely measure ammonia, because I completely agree with Elliot that the likelihood of this patient having hepatic encephalopathy is high in this situation. But neither confusion nor flapping tremor are specific. The test is cheap. We haven't touched on this, and can be obtained very quickly. And individuals who are or have been alcohol misusers are much more prone than the rest of the population, for example, to hemorrhagic strokes, to malnutrition-related forms of hepatic encephalopathy, vitamin deficiency forms of encephalopathy. And therefore, again, differential diagnosis is important also in this situation.
Okay, thank you. Well, when we looked at the poll on X, we had 73% saying no to measuring ammonia and 27% saying yes. So again, that probably represents our conversation on that scenario. So let's move to another scenario, shall we? So we're in the clinic this time. And you've got a patient that you're seeing, maybe that you review 6 monthly with stable alcohol-related cirrhosis. They've been abstinent for 3 years, so there's no issues with alcohol withdrawal or anything like that. And they're telling you in the clinic that they're feeling tired. Maybe they've got some sleep disturbance or some sleep-wake cycle reversal, and they've got some short-term memory loss. They're struggling a little bit. So I guess you're thinking maybe this patient might have some minimal or covert hepatic encephalopathy. Would measuring ammonia be useful in this scenario, Elliot? What would you do here?
So to me, again, here are the main points. One is we want to listen to the patient and elicit these kinds of symptoms and determine who might benefit from an HE-directed therapy. And like Dr. Montagnese says, there's a differential diagnosis at play here, particularly hammered home by people like Dr. Pajaj, who've shown that this is the same presentation that could befall someone with obstructive sleep apnea. But ultimately, we sort these things out with time-limited trials of therapy. And the issue that ammonia has here is that we might adjust for the upper limit of normal, but those upper limits of normal were established arbitrarily by our labs and not conditioned on the presence of covert encephalopathy. And for that reason, I'm a little bit more pessimistic about the ability of an upper limit of normal to help us solve this dilemma. And rather, I'll wait and see how the patient does with an intervention.
So you go straight for the intervention. And Sara, you're a sleep expert here. So if we are struggling with our differential and we're thinking about things like sleep apnea or maybe other issues going on, how would that influence whether you would measure ammonia in this sort of scenario, or how would you sort of approach that?
For sure. I mean, here in the description of these patients, there are, however aspecific the clinical profile of metabolic encephalopathies might be, I would say that tiredness and a tendency to sleep-wake reversal would direct me towards a diagnosis of mild encephalopathy. Memory would not. I mean, with the exception of working memory, generally memory is untouched by hepatic encephalopathy. So here, I think the main differential is any form of dementia. And if I took ammonia, which I would, and found it to be normal, I would set up a dementia workup, which is what we regularly do in our outpatient clinic, where we see many people with these features.
Okay, so that's interesting. So you're using it to help you rule out or rule in something rather than to purely diagnose. And what about you, Rajiv? Because you've obviously mentioned using the upper limit of normal for ammonia, and I know that some of our researchers suggested that a level of more than 1.4 is relevant. How would you kind of use that kind of research in a clinical setting in your clinic to make decisions?
So, this is a patient who, my biggest worry is twofold. The first, of course, as has already been alluded to, this patient is symptomatic. We need to do something about it. But of course, my biggest worry here is that this patient's risk of developing an overt hepatic encephalopathy requiring hospitalization, leading to increased risk of morbidity and mortality that would bring. So if you developed hepatic encephalopathy grade 2 or more, the risk of death for this patient is 5 to 10%. And that is what I want to avoid. And what I think we've shown very nicely in the work that I've done with you, Debbie, and with the work that has come out of Vienna and others, there are at least 4 or 5 really good papers now, which show that 1.4 upper limit of normal predicts with the greatest accuracy whether this patient is going to develop an overt hepatic encephalopathy episode. If that was present, I would absolutely go for prophylactic therapy with vigor for this individual. But I just want to make a plug for the AMON-OHE score, which has also been defined, which is a composite of ammonia, creatinine, albumin, sex, and the presence or absence of diabetes, which performs fantastically well in categorizing patients at risk of development of overt hepatic encephalopathy. So the answer is absolutely yes, in terms of categorizing the risk of development of overt hepatic encephalopathy and going prophylactic therapy very hard.
Thank you. And actually looking at our X poll, actually, again, things were split fairly 50-50, actually. Yes and no to measuring in an outpatient setting. So clearly people are very open to thinking about this. So I'm going to throw another scenario at you because I think it's very helpful to think about it this way. So slightly different scenario now. You've got a patient that you're performing an elective TIPS on. They've got diuretic resistant ascites, and significant portal hypertension, but their MELD score's 10. So they're quite well otherwise synthetically compensated. But on day 3, after you do the TIPS, they develop quite overt hepatic encephalopathy. Is it useful in that sort of scenario where you've created a shunt to measure ammonia, or would you just get on and treat? I'm going to go to Elliot.
Yeah, so to me, this is a slam dunk. Not only are they exhibiting symptoms consistent with encephalopathy, but we just did something to them which we know causes encephalopathy. And so regardless of the ammonia level, I need to intervene now to see if I can resolve the situation, whilst also being mindful of the fact that they could have developed an infection along the way, potentially triggering all of this. But part of the sort of ABCs in this management are going to be HE-directed therapy while also making sure they're hydrated and not infected.
Thank you. Thank you. Sara, what would you do? Would you do the same?
I think this is an interesting situation in many ways, because here, not only is the likelihood of the patient being encephalopathic very high, but the likelihood of the patient being hyperammonemic is also very high. So I think in this situation, probably for an immediate decision, one could do without, but one should also always consider that however rare, mixed forms happen. I can never forget a patient I had who had a stroke after a TIPS. And of course, he had a stroke and he was also hyperammonemic. So in this respect, the response of ammonia levels to ammonia-lowering treatment could be helpful, but still, it is a situation where I wouldn't strongly require an ammonia level.
Thank you. What about you, Rajiv?
You know the answer, you know. Of course, I would measure ammonia in this individual. This is a very dangerous scenario, Debbie, as you know. That is, you know, post-TIPS coma, advanced HE can be associated with cerebral edema. And, you know, there are nearly 5% cases of acute and chronic brain injury is associated with cerebral edema, as again, and you've shown this in the paper that you guys published. And these patients have very high ammonia levels, 150, 200 micromoles per liter. And if you were to find that, this would tell you to immediately put in a vas cath and to dialyze them very hard so you can get their brain edema down. So 100% I would measure ammonia levels. If it's anywhere above 100, it would tell me that I should dialyze this patient immediately.
But if the ammonia level wasn't so high, would you still dialyze them?
No, I wouldn't. So if
No.
it was not, then I would just manage him like Elliot suggests.
Okay. I'm going to cover one final scenario very quickly because I'm conscious that time is moving on. And there's been a lot of controversy around hyperammonemia in patients with metabolic steatotic liver disease, particularly hepatic steatosis, even in the absence of fibrosis and cirrhosis. So if you were seeing a patient who maybe had a raised BMI in the clinic, mildly deranged transaminases, who was reporting symptoms that might be suggestive that they have some neurocognitive dysfunction, is there any role for measuring ammonia in this kind of setting? I'm going to go to you, Sara. What do you think there?
Well, if I took an ammonia sample, which at this time and age I probably would, and found it to be normal, then I would be very comforted in my suspicion that this is sleep apnea rather than anything else. So again, to rule out rather than rule in.
Okay, what about you, Elliot?
So this is a situation where we do have some data, right? And so from like Dr. Lauridsen, Denmark, who has a wonderful registry of patients across the spectrum of MASLD MASH. And here, ammonia levels did not correlate with health-related quality of life. And so I believe in the science as advanced by Dr. Jalan about the role of ammonia potentially in some pathogenesis that hasn't quite translated to the clinic or the clinical phenomena that we encounter in earlier stages. And so, no, I'm not checking ammonia in this situation.
You're not checking. What about you, Rajiv? I guess you are.
Well, you know, I think this is here, I'm sitting on the fence, and it is not an absolute that I would measure ammonia in this patient. Here, ammonia is interest to us from the scientific and pathophysiologic perspective, because we've got a long study which is ongoing, where we are investigating the role of ammonia in progression of liver injury in NAFLD. Quite apart from what happens in the brain. And as you might have seen recently, there's a really nice review from Karen Thompson and colleagues describing ammonia in NAFLD. There's a beautiful paper from Anna Hajihambi who shows the importance of NAFLD hyperammonemia and brain dysfunction, and from our own group with Francesco Di Chiara showing that ammonia can lead to progression of fibrosis and NAFLD. So it is of scientific interest rather than a clinical requirement in this particular patient at this time.
At this time, yeah. Okay, that's maybe a topic for another studio, I suspect. Okay, so we've covered some clinical scenarios, but maybe if we could just cover one or two other topics just before we call the studio to an end. And I'm interested in guidelines, Sara, particularly, and I know you chaired the EASL CPG, the Clinical Practice Guideline on Hepatic Encephalopathy. There's also an ASLD HE guideline as well. And is there anything there that can help us with understanding where we can use ammonia, or do we need to look at the clinical scenario in very much the way we've been discussing?
Well, the EASL guidelines very much depict a clinical scenario, because the element pertaining to ammonia in the EASL guidelines states that if a patient with cirrhosis is confused, ammonia should be measured, because should it be found to be normal, the diagnosis of hepatic encephalopathy would be problematic, to say the least, and this should prompt a rapid workup towards differential diagnosis. In the small writing, there is also, in my view, a very important message. The guidelines basically state that there is no hepatic encephalopathy without hyperammonemia, while the opposite is more than possible. We find people who are hyperammonemic and do not develop the phenotype for different reasons, which may be age, capacity of compensation, and so on and so forth. So it's a very simple message that comes out of the EASL guidelines. There is no such thing as a syndrome that we can call hepatic encephalopathy without hyperammonemia, while the opposite is not necessarily true.
Okay, that's very helpful. Thank you. And then the last topic I just wanted to have a little think about is in hepatic encephalopathy, we don't have many therapies to choose from, you know, over the years there's been very little development, and we've struggled to find new things to treat those really difficult patients. And so I'm thinking about clinical trials and the development of new therapies, particularly maybe therapies that are targeted at ammonia lowering, but maybe therapies that aren't. And I know, Elliot, you mentioned that the FDA don't allow ammonia to be used as an endpoint in clinical trials. Correct me if I'm wrong. So you know, is there a role at all here when we're looking at drug development and we're looking at clinical trials as to where measuring ammonia could be helpful, or do we just need to forget about it and look at clinical endpoints?
Oh, ammonia is definitely helpful in the context of clinical trials in a number of ways. So just to put a pin on this point here, that in order to get a drug approved by the FDA or the EMA, one must improve clinical outcomes. And those clinical outcomes have to be that the patient was diagnosed with overt hepatic encephalopathy by a hepatologist of the quality of Dr. Jalan, and that they responded to HE-specific therapy, that there was a reversal of that syndrome. And that is the burden that must be satisfied in drug development. However, ammonia is going to be helpful in two ways. One, demonstrating the mechanism of the therapy, and two, demonstrating who is a candidate. Because if we take that line that there is no encephalopathy without hyperammonemia, we are blurring over some people that have Rip-Orin sepsis and encephalopathy. So we are only going to select for intervention those people with hyperammonemia, and you will need that biomarker to initiate your specific therapy if that is the mechanism of action for your drug. So biomarker for patient selection, proof of mechanism, but not to get it over the finish line for approval in phase 3.
That's really helpful. But, you know, also measuring ammonia has kind of been the death, actually, Rajiv, for many compounds that we've been looking at in trials as potential new therapies. So can that be a little bit dangerous at the same time? What are your thoughts there? I mean, what happens if we don't show that ammonia is lowering in trials?
So I think, you know, the point that Elliot makes is a good one as to, you know, what is the hypothesis behind your intervention? And so if the intervention is designed to reduce ammonia concentration, And if it doesn't do it, then that is not such a great drug to have. But we now know, and we've known for a long time, that ammonia is contextual. That is, the same level of ammonia in the context of infection works a lot, makes you encephalopathic compared with the same amount of ammonia with no infection. The same amount of ammonia with an older individual is likely to make you encephalopathic compared with the patient that's not. And so therefore, there is a school of thought that suggests that we may treat the effect of hyperammonemia rather than ammonia itself. By that, I mean that, Sara was very closely involved with this drug which targets neurosteroids. And so it is the effect of hyperammonemia. We're interested in a TLR4 antagonist to treat the effect of hyperammonemia. I may not lower ammonia, but I may reduce its effect on the brain. So fundamentally, we think that it is a little bit more nuanced and a little bit more complex, where ultimately, as Elliot says, the FDA or any regulator is interested in making sure that we resolve HE. And if my drug is designed to reduce ammonia, of course, I have to measure it and show that it does pharmacodynamically what it's supposed to do. Rifaximin is the best drug we have for encephalopathy at the present time, and its effect on reducing ammonia is very marginal. But we know it's effective because it reduces the effect of ammonia on the end organ. So ammonia may still be elevated, but you reduce inflammation, reduce endotoxemia, and therefore it works on the brain. So I think that it is complex, and therefore at the end of the day, the approvals are related to the patient getting better, and the drug development requires showing the mechanism of action.
Thank you very much. So I'm conscious that we're coming to the end of our session, but Sara, I'm going to give you the last word on this. What's the takeaway message, do you think, for our viewers today? Is it all about nuanced care and thinking about the scenarios? What is it for you?
I think that the take-home message is that ultimately ammonia is an important piece of information that we can obtain fast and cheap and can direct our decisions in most, I believe, of the scenarios we have explored. And exactly in the same way as glucose does not necessarily correlate with the depth of diabetic coma or the severity of the cognitive dysfunction, but you wouldn't find one diabetologist on the planet that would suggest not measuring it. I think we should go exactly the same way. Ammonia should be measured.
Thank you. That's a really nice analogy, actually. So look, I'd like to draw this studio to a close and to thank you all, to thank you, Sara, Rajiv, and Elliot, for your your insights and thoughts today on this topic, which has divided many people. So thank you very much. And I'd like just to now give a little bit of a plug for next week's studio. For next week, we're going to actually be exploring hepatocellular carcinoma and the limitations of the current BCLC system, and discuss an innovative new treatment algorithm, as well as implications for the fresh approach to management of HCC patients. So that's a bit of a plug for the studio next week. And I'd just like to finally say good evening to you all, and to remember to become an EASL member and join the EASL family if particularly you've enjoyed the studio today. So thank you very much, everyone, and good evening.
Thank you.